Welcome to the Heart of Innovation, where today we're going to be discussing a medical breakthrough that could truly transform treatment for peripheral artery disease, PAD. It's that poor circulation in mainly the legs that when it reaches advanced stages, known as critical limb ischemia or CLI or CLTI, critical limb threatening ischemia, it could be limb threatening. You might remember the viral video where Coach Prime Deion Sanders revealed his vascular surgeon believed amputation was inevitable for him because while they could open these small arteries that were blocked, that were below his knee, those vessels would just simply close up again, right?
Okay, how do we get those back open?
Well, you can get them open, but the chance of keeping them open are not very good.
Gotcha.
Now, he was never diagnosed with PAD, but there's a similar treatment for hypercoagulability, meaning blood clots, and he had a lot of blood clots below his knee in those arteries. And the doctors were hesitant to treat him, but his doctors did, in fact, proceed with treatment anyway, giving him the best chance to keep both of his legs. But most patients are just not so fortunate. Many doctors will not even attempt to treat small arteries below the knee, not because they can't, but because they believe these interventions just delay the quote, inevitable, unquote, which is amputation, through an expensive revolving door of treatments. But today, we are focusing on Reflow Medical's groundbreaking development, which could change the game for these patients. A temporary stent system that can be completely removed after opening blocked arteries below the knee. This FDA-cleared technology represents a new approach for treating patients with critical limb ischemia. Now, you might be wondering, how can it be that a stent is removable? Is it truly effective? What about long-term results? Now, before I introduce my co-host, Dr. John Phillips, who did have the honor of being the very first physician in the entire state of Ohio to use this device since its clearance, I really think it's important to note that Reflow Medical is a sponsor of our show. But as an Emmy Award-winning journalist, I would never accept a sponsorship from a company if I did not believe in their mission. Covering their technology is not part of the sponsorship. In fact, they preferred to remain in the background. This decision to feature their FDA clearance is made with complete journalistic integrity. And because I truly believe, as the FDA did in granting their de novo clearance, that this technology truly represents a significant advancement for patients with PAD. Now, with all that being said, let's welcome Dr. Phillips before we bring in our special guest of the day, Dr. Jay Matthews, who is the lead investigator for the trial that led to this innovative approach that just got clearance that's giving new hope to patients struggling with PAD. Welcome, Dr. Phillips. It's been so long since I've talked to you.
I know, Kimberly. We see each other like what, twice a year, and I was able to touch base with you in person, actually at a Reflow symposium at NCVH last week. So welcome, and you know, I am not an Emmy Award-winning journalist. I hope to be one, maybe, and who knows? But I will tell you this: today, and we'll get into the case and all that good stuff, but it became clear to me that there was the possibility that we did not have all our ducks in a row, I's dotted and T's crossed regarding the device that we were going to use. And in that instance, will there be reimbursement to the company from my health system? And Ohio Health, they did a great job trying to get us what's called a purchase order to make this work in the business transaction. That is medicine sometimes. But I will say this, the team at Reflow, when I asked them, I said, listen, guys, I don't know if we'll be able to get this, get you guys paid for paid for this device. And Gunter said, we're not into products, we're into patients. And so we will eat the cost if we have to. And again, you mentioned it. I believe in their mission, and we and Jay can attest to this as well. We try a lot of devices because I think that's how you advance any field, and we give them, I hope, honest feedback. And I feel, at least with this first case, that I've got pretty good feedback to give that's positive. And I just thank Reflow and their team for supporting our mission and supporting the mission of treating patients and not products. So with that said, looking forward to the conversation. Jay's got a lot of experience with the device. And we're just going to maybe dive into a little bit of the protocol research, a little bit behind it, what it looks like now, how we roll it out, all that good stuff. So we're going to have a fantastic show.
And I love that you mentioned at their core with this particular company that they are about patients versus products, because when they started this sponsorship, one of our major educational opportunities that they have helped me with throughout the past year has been with the Walking is Medicine initiative to educate patients on the importance of walking. Walking is the best medicine for PAD, and that you need to walk to try and grow your collateral vessels, those extra arteries that reroute blood flow around the blockages. Now, only at that point where you have tried walking and you can't seem to get a break, you get a wound on your foot that's not healing, you have Charlie horses that wake you up at night, and the only way you get relief is you dangle your legs over the side of the bed or start pacing. That's when you get a procedure, but that's only the beginning. Then you got to walk to maintain it. So it is all about walking, and Reflow Medical is all about the patients and promoting that. So I'm excited to
And
get into the core of this
that little
device.
patients before products thing, that's me and Gunter. So the alliteration is there. The P's are good. So, we're always trying to look for a hook. So we may have another hook there. So, because there's another little hook that I'll share with you that Gunter came up with too.
Gunter is the senior vice president, right?
Yes, I'm sorry. Yes.
Of Reflow Medical.
Yes. Yes, he is. Enough
Just
of that.
making sure. I mean, we're all
Correct.
friends here. We're all talking. It's great. We're just welcoming everyone into the conversation. But before we continue this conversation, we got to bring in Jay Matthews. So let's start with a moment of inspiration.
Dr. John Phillips, spectacular vascular moment of inspiration.
So I'm going to use a quote from Rabbi Nachman. I'm probably not pronouncing his last name right, but I've heard this several occasions, and I think it's poignant when you are potentially using new equipment or just kind of, they say fortune favors the brave, and not like we were splitting the atom here, but again, you're using something a little bit new. And I love this quote, but he's quoted as saying, "The entire world is a narrow bridge." And I think the essence of that is that you could misstep anytime and fall and plummet to your death. Therefore, the essence of life is to really have no fear, not be afraid, and trust that there is a reason why you're doing what you're doing. And I honestly felt like today there was a reason why all these kind of stars align, that we were able to kind of get this case done, have a good result. And at the end, ultimately, you're here for the patient. You want to do what's right for the patient and treat the patient and save the piggies. I think we were able to achieve that. But I've been telling some other listeners that I hopefully are hopefully listening that the entire world is a narrow bridge. So have no fear.
I love that quote. And I'm curious with Jay, we have just a couple of minutes before the break for you in. What are your thoughts on that quote and how it applies to you being the PI for this breakthrough study, for this breakthrough device?
Well, I mean, it was a real honor to obviously be able to participate with this and a number of other technologies. Obviously, it's always, we're always trying to push the envelope and try to do the best for our patients and try to seek out better solutions and better ways or better mousetraps to solve a really complicated problem that is PAD. So, it's just amazing that we have this opportunity in this day and age to have access to this. There are a lot of places around the world that are not so fortunate. And, I really look forward to continue to push the envelope.
Coming up next, right here on the Heart of Innovation, we're going to get into the core of this technology, the Spur technology by Reflow Medical, and we're going to talk about why it truly matters and why it may be the biggest breakthrough for patients who have PAD, who also have diabetes and chronic kidney disease. So stay with us. You don't want to miss a moment. Don't go away.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just step
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible lab you have here.
Without a doubt, we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should, because it is a killing disease, it is a disabling disease, And most importantly, it's a disease that we now have great treatments for.
Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
Welcome back, everybody. Thanks for joining us. Welcome to Dr. Jay Matthews, a good friend who I've known for quite a while. We were residents together. And so, Jay, let's talk about the technology. If I understood it correctly, the co-founder of the company, Reflow Medical, about 10 or so years ago, was at a conference, and he had an idea based on looking at his wife's hairbrush of a device that could potentially kind of poke like little holes in the vessel and help treat the vessel, open it up, and maybe deliver a little bit of scaffold or structure for a short period of time, and then, remove that from the body. 10 years ago, that probably sounded pretty crazy. It still sounds a little goofy today. But tell me how you got involved with the company and the device, and, what got you excited about being involved with their trial.
Yeah, so I've had the pleasure of being involved with these guys pretty much since their inception back in the days when they were just a crossing catheter company. So little tubes that we use to push through chronic blockages. And, I helped them kind of guide some of the development of some of those catheters. And then that's when they kind of proposed this idea, which I thought was pretty wacky at the time. This idea that we would put a stent in, but actually take it out. This term retrievable stent technology, there's no such thing that existed in the vascular space. They've done some things like this too for folks in the urology space, for kidney stones and things like that too. But this was very unique in design and very different, and didn't make a lot of sense at the time. But over the countless years of testing and in early work in the lab and whatnot too, before we even got into humans, really kind of started to understand what was actually happening. And really also we took this technology, and before it even came to the United States, it was being used in Europe for quite some time, and really excited in terms of like the results that we were getting over there, and then what's possible for the future as well.
Can we talk about what a removable stent really is? What does that look like? And
Yeah.
how does it maintain the same value of a regular stent that is left in over time?
So maybe we should talk a little bit too about what's available. So a stent is it's a mesh tube, and the type of stents that we use have what's called memory metal in it, or essentially, once it heats up in the body, it actually takes a shape that it wants to expand out fully. In this particular case, because it's retrievable, we can actually collapse it back down and take it out of the body. But when it comes to dealing with blockages, especially the type of blockages we're talking about are the small arteries below the knee, the ones that are really, really challenging to treat and lead to ulcers and gangrene and other bad things and peripheral arterial disease. We just didn't have a ton of options. For the longest time, we had just balloon therapy. And really that's, the problem with that is the vessels will recoil back down again and collapse. And then, we have also tried durable metallic stents. The problem with those metallic stents is that they're quite stiff and they don't go away. And so they unfortunately can impact, the way the artery moves. You can only use them in certain locations because they're too stiff. And then we now, more recently had the development of a type of stent that melts away. That's a resorbable stent. And that seems pretty cool, but again, has some limited applications. They only have very short lengths, and really we don't know if it works over a long distance. And now this new concept of a retrievable scaffold or retrievable stent is you put the stent in, and then it assumes the shape of the vessel, fully expands the vessel outwards. It's got little spikes on it as well too, to kind of puncture some of this fibrous tissue that may cause the vessel to collapse otherwise. And then once we feel like the blood has been flowing for a bit, we feel like we've got a good expansion, then we can collapse the balloon down, collapse the stent, and take it out as well too. So it's truly a leave nothing behind strategy.
Yeah, and I think ultimately what we struggle with is these vessels are long. There's a lot of calcium in it. They're tortuous. And so there's a lot of kind of headwind that we're dealing with. And anytime you have a device that can potentially act like a little bit of a scaffold, may help, change what we call the compliance or the memory shape of the vessel long term. And because the goal is to heal these wounds, right? And also leave nothing behind. So these folks typically sometimes you have to, repeat procedures. It's like going to the dentist, right? Sometimes you got to go back in. And anytime you put a stent in, I think that kind of limits some of our ability to kind of treat it at the next time and the next time. So this is a fun technology. We've got about a minute left, and I think at next segment, we'll probably dive into some of the research behind it. But, Jay, from your standpoint, when they kind of said, hey, let's be the national PI, did you buy into it, or were you kind of like, well, we'll see what happens?
No, I had the luxury of being involved with this technology since the inception. So I kind of felt really close to the technology, especially from the early development phase to what was the product that was used within the trial. So it was a no-brainer for me. I mean, I definitely wanted to guide this therapy.
I'm curious, before we go to break, just how has it evolved from day one? You must have, from the very first case till now, it's probably a very different product.
Yeah, I mean, from the moment that it was developed to what actually went into patients, just the length of the spikes, the stiffness, the trackability, the coatings used, all these things changed to continue to refine it and improve it before it actually got into humans. So what we're using now is very different than what we started with. And then I'll tell you that in a few years, what we'll have will be even different. It'll be faster, smaller, better. And, potentially we're going to be starting a randomized controlled trial with drug coating on it too to improve patency.
And coming up right here on The Heart of Innovation, we'll have more with Dr. Jay Matthews and Dr. John Phillips, because we want to hear about their cases and how they've used the products, as well as all of the results. So don't go away. Stay with us right here on KDOW, The Heart of Innovation.
Your type of condition is called critical limb ischemia. It's the most advanced form of PAD, or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to PAD and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years, and my husband had to quit work.
I didn't know what to do at this point because we had had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with PAD.
And all I heard was, "What are we doing here? Just cut it off." And I pulled the curtain back like, "Are you kidding me?"
Do you really want to go through all that?
That's crazy. That's insane. The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options. We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Welcome back to the show. Continuing our conversation with Dr. Jay Matthews, as well as Ms. Kimberly, Emmy Award-winning journalist, and myself, non-Emmy Award-winning physician. So, Jay, let's continue. Real quick, you mentioned the time. This was 10 years to fruition. I think people don't understand what it takes to get something on the shelves that that physicians can use with FDA approval and clearance. You got an idea. This is 10 years. This is probably millions of dollars. This is lots of person power. and it's an army of people. And I think it's just a testament to the innovation that occurs in this country. I mean, this show is called The Heart of Innovation, and that's what we're about. But I think it's really cool to see something like this come to market because it's completely wacko, in my opinion. But I think it's going to work. It certainly worked for my case, and we did 3 arteries with one device. I mean, it's fantastic. But I mean, just give us a couple of minutes about, how you understood this process and learned from what they did and the amount of effort and work that time that went into this.
Yeah, I mean, so when it comes to devices, and especially this is different than, say, some of the other devices that are on the market that are what we call iterative, or like they're essentially you use another device and you're kind of copying it and you're creating a slightly better mousetrap. The approval process or something like that, it's still very expensive, still takes a lot of time, but it's a lot easier. It's what they call a 510(k) approval process. It's just kind of a technical term, but it's typically quicker to get to market with that too. Maybe you can get to the market after 2, 3 years of development. But then this is something different. This is called de novo. Literally, they're creating a brand new therapy, a whole new space. It's a much more difficult process, and that's I alluded to the fact that this whole process took like 10 years, and so that means you're designing it, you're incepting it, you're playing with it, doing all this stuff, and then we go through all sorts of testing and there is some animal research that's involved as well too. I know there's some ethics behind that, but that's a lot of times that's necessary from the FDA to show that it's going to be safe to use before we even try it in humans. And a lot of times when we do try it in humans, we do what's called a first in human, and that's done oftentimes overseas somewhere, and we get some early experience, and we use that then to do additional safety analysis before we go into an early experience. And many times that early experience is done outside the United States. So before a product ever makes it into the US, it's gone through years of testing, which is required. And then in many situations, if we want to get special approvals, we have to do another trial. We may have already done a trial elsewhere. We do another trial in the United States. And then that information is what's used to guide the approval process or the FDA approval to bring it to the public for commercial use.
And just real quick, it's really important, I think, for our listeners to understand that research and these new clinical devices only occur when we get the buy-in from our patients. They have to trust us that, hey, we want to use this device. You're going to get standard of care. We believe in the device. But none of this stuff happens if patients say, I don't want to be your guinea pig, right?
Yeah, I mean, it's right. I mean, none of this happens without the help of our patients because it's, and whenever we talk to patients about a new therapy, we have to have buy-in too, because obviously there's sometimes risk with these types of things, and we discover things along the way that were unanticipated, and that requires a pivot or a change. And sometimes you have to shut the whole trial down, and sometimes you have to do what's right.
What was that conversation like today with your patient, your very first patient?
Well, I mean, so again, my patients, and I think Jay's most of our patients are not put under general anesthesia. So they are hearing the case, okay? They get a little bit of twilight, but they're awake. But before the case, we did the procedure. I said, listen, sir, we have an opportunity. This is an FDA-approved device, but we're just kind of, getting our feet wet on it. I think if I'm understanding you're testing correctly and the pictures look okay, you'd probably be a pretty good candidate for this. And he was all in. I mean, he was super thankful. I explained it to him and his wife. They were very grateful that we were able to get the case expedited to him. We got, a really nice result. And I said, and then at the end, I asked him, we're going to ask for a media release because we want to share this information with their team, and we're all learning, right? Like Jay said, there's iterations. We can tweak how we do the procedure and whatnot, and we're all learning together. And if we can use your case and teach other physicians or members of the Reflow medical team or any other in industry company, yes. And he's like all for it. So we're gonna share his case, and he was all for it. He was all in.
So what makes this, Dr. Matthews, you said it's de novo, right? It's a brand new therapy, and it's just not a better mousetrap in a sense, which was what a lot of other companies were doing, trying to constantly innovate around treating the Achilles heel of what I consider PAD, which is, it's those long calcified blockages or even, thrombotic blockages below the knee. What is it about this new treatment that makes it so different that all of these doctors that have been resistant to doing anything below the knee and instead just saying, hey, walk, 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 when you can't walk anymore, we'll chop it off. What's going to bring them on board to say, hey, this is the game changer. I'm going to start treating below the knee now.
Well, yeah, I mean, I think there are still going to be a lot of naysayers out there and people that aren't 100% on board because we haven't had great durable therapies until recently. And again, we're limited still. And I'm not going to tell you that this device is going to be the end all be all because I do believe that we have other iterations of this device, specifically one with drug that we're going to be investigating that's going to be even better. And what I mean by drug is sometimes we use medications to help prevent the blockages from coming back. But we were really encouraged by the results of the study that we did in terms of their acute outcomes and also some of the later outcomes as well too, that a lot of these patients, they healed up afterwards and they had good results as well too. In fact, I just did an angio tonight right before I got on this call that was a patient from that study, completed it, and the area that we had treated with the spur was still open a year later. So pretty exciting. Nobody else knows this. I literally just did this. And so, I mean, this is the kind of stuff that I think, we're looking for something that gives us long-term outcomes. It's certainly better than just simply ballooning, which just doesn't work that well.
And it's interesting too, because as cardiologists, we place stents in the coronary arteries, and those stents last for many, many years. And so, we have this mindset that these stents should work everywhere else, but they just don't. And I think it's also a little bit counterintuitive to deploy something that it's like a cage basically that with the little spikes on it. It's like a pipe cleaner, right? But then you just kind of bring it down and move it around and use multiple. You can use it multiple times, which is kind of neat. But it's a foreign concept, and I think part of why we do this show is to just kind of start the conversation about something new, how we where we think it applies. And to Jay's point, this is not the silver bullet. Nothing's a silver bullet, but I think this is a different mousetrap, and it's really exciting.
So if people actually develop the stent, right, that's that metal scaffolding for the long term, right, then why is it that a scaffolding that can be retrieved right away is going to potentially have the same, result long term, like, for example, in the coronary?
Yeah, so it's interesting. As John was mentioning, we think that, hey, we put a stent in, we're going to get nice long-term results. Well, it turns out that those medicated stents that we put in the heart work pretty well just for a very tiny portion of the below the knee arteries, those tibial arteries. And it seems like if we start putting them anywhere else, like further down, there's a risk of them getting crushed or clotting off. In fact, we studied this in some other trials. It was a study called the Saval trial that they looked at these long medicated stents, and it turns out it didn't work very well. And so we need to do something different. And that's where we realize that sometimes leaving something behind long term may not be a good plan. And that's where this idea of retrievable stent technology came about.
Coming up right here on the Heart of Innovation, we'll have more with Dr. Jay Matthews and Dr. John Phillips and their experience with the brand new FDA de novo clearance of the spur technology. Stay right here on KDOW in the Heart of Innovation. Don't go away.
As I started to look at the literature and realize how many people are given as their first option an amputation without a vascular consultation, without an angiogram, without an ultrasound. And I started to say, how on earth can we as an advanced nation do this? And this, by the way, is happening all over the world, still is happening in the United States of America. I cannot fathom that is okay. Cannot fathom that. We are not yet able to save every single limb. But we absolutely know, and we have reams of data, that getting an angiogram before an amputation saves limbs, because many of those actually have easy options. So there have been many defining points, many things that I've seen throughout my career. Certainly some of the more recent articles which have stopped people from using atherectomy, stopped people from using IVUS, even though there are reams of data showing that IVUS is helpful. Those have further shaped me. In fact, have made me a little belligerent, frankly, in how I approach studies like Best CLI, which I thought was a terrible study that came to very poor conclusions. The New England Journal of Medicine did take my letter to the editor, did publish it, where we, brought out the criticisms of that. I told him, let's wait and see what happens with the Basel II trial. And the Basel II trial completely had an opposite conclusion because that trial was biased. So there have been many things that have shaped my opinions, but I am trying to be balanced. I try to look at both sides of the equation. I'm hoping that not just me, but each of my colleagues and that others make a point of looking at both sides of a coin and assessing all things, and then saying, what is our best option here? And you know what? That may be different for different people. There may be a surgeon with such fantastic skills that his bypasses always work and they never go down. There may be an interventionist who never fails and it always gets the perfect example, the perfect outcome. And that's the art. Just like you could give me all the same paints, all the same oils, all the same canvas used by Monet or other people, I wouldn't have the same result. Even with the same tools, even with the same diagnosis, even with the same dreams. And so I think that's the art of medicine. I think we have to quit criticizing the art of medicine as we go on. Certainly, there is no room for people doing anything unethical. Certainly, there's no room for taking advantage of patients, but there has to be room for differing opinions.
Yeah.
And when we try to
it's still a practice.
when we try to quash those, it's an error, and that's how we'll stop progress.
Welcome back, everybody. Thanks for joining us. So, Jay, in our minds as interventional cardiologists, and I mentioned this before, but we pretty much have cornered the market on how to treat blockages in the heart arteries. We see a blockage, the patient's having symptoms, we put a little balloon in, then we put the metal scaffold stent in, it's got a little drug on it, the body kind of seems to like it there, and the vessel stays open 10 plus years. Oftentimes in the legs, and particularly below the knee, which is what we struggle with, particularly in patients who have critical limb ischemia or ulcers or significant rest pain due to the blockages. We haven't really cornered that market yet. And like you said, we've tried various things. And I do think that the Esprit bioabsorbable scaffold from Abbott is promising, but you're not going to put that everywhere. So we have to think differently, and the spur device is a little bit different. It's this little, the little cage that kind of looks like a stent, but it's kind of memory-shaped metal and it has little spikes on it. So tell me, what do you think the spikes do? Are the spikes kind of like getting into that middle portion of the artery and maybe breaking up some of the fibrotic tissue to let it kind of pop and then relax? And then will that keep the vessel open? Because people are asking like, well, the stent props the vessel open. How is this little device going to do that? Because you're taking it away. You're just kind of, you cover it up again, right? And it kind of folds down like an umbrella, so to speak.
Yeah, it's a good question. It's a combination of factors. So the retrievable stent, it has an integrated balloon. And so when you unsheath or expose the stent, it expands outward. Those spikes start to penetrate into that wall. And then the balloon is inflated, and then it pushes those spikes in. And, these below the knee vessels, the ones that recoil a lot, have this layer of calcium underneath that soft tissue, but in the wall. It's called medial calcinosis, or there's a lot of different names for it, essentially. And that calcium is oftentimes what really makes things difficult for keeping these vessels open, because everything just snaps back shut again. So by essentially puncturing that calcium and creating all these little microfractures, it makes the vessel a lot more pliable and flexible. At least that's what we think. And so those spikes break that fibrous tissue and also break some of that calcium apart. And then that stent cage is able to fully expand. Now, at this point, what we do is we deflate the balloon and we just leave this cage up, and blood is flowing. So that way you can still get blood flowing down below the knee. And you can leave this thing up for as long as you want. But in the trial, the whole process took about 6 minutes or so. So, we would inflate it up for a couple minutes, deflate it for about 3 minutes, and then one blast balloon inflation at the last minute, and then deflate everything and retract it out of the body. Now, in the real world, people probably won't do it for that long, but that's what we did in the study, and that seemed to work really well. And what was interesting was that when we took cameras down afterwards and looked at these vessels, it maintained the shape. So the vessel didn't recoil, which is something that was seen very often, even several minutes after doing other types of procedures. So with this procedure, that recoil didn't seem to happen. The vessel seemed to stay open. And so that's what was really encouraging as well, too, towards, that we could actually do this, leave it up, take it out, and then able to maintain that same shape as if the stent was there, even though it was not.
And the recoil is that's a big problem. I mean, you start seeing that within 15 minutes of just using a standard balloon.
Yeah.
Part of why we place the stents is to prevent the recoil. I can tell you the case that we just did. So we treated all three, the anterior tib, posterior tib, perineal, all three vessels. And so from the time I started the first vessel, which was the posterior tibial, to finishing with the perineal, it was about 40 minutes. And so we had a runoff of all three vessels. And so that posterior tibial artery, 40 minutes after the procedure, looked pretty darn good, honestly. And we used the camera, we looked at it. And I think it's just, it's important to understand the technique as well. And I think, like, as you and I potentially train physicians about or talk about these things, you have to kind of follow. Now, again, is someone going to do 6 minutes worth of ballooning? I don't know. But I mean, I think it's important to kind of follow the recommendations of the device so it works properly. But it worked really well, and I know I was really impressed, because oftentimes when I just do balloon angioplasty, you kind of take that picture and you're like, all right, it looks pretty good, but what's it going to look like in 10 minutes type deal? And so This was 40 minutes afterwards, you got a nice result.
And so I'm curious, Dr. Matthews, in terms of the study results, you said that you had done quite a few, not necessarily you, but in the trial, there were quite a few cases that were done overseas. Do you have any data that shows the longest that the vessel has stayed open following the use of this?
Yeah, I mean, we have data over 6 months with showing excellent results, and that's typically the major metric for most of these trials. And then, we have also 12-month data that's essentially going to be forthcoming as well. And then our own 6-month data from this trial, will be fully released very shortly. Now, what we do know from this study, that out at 6 months, there was a high freedom from bad events. So essentially, the vessels primarily did tend to stay open. There weren't a lot of cases where people had to go back and do a lot of additional interventions. So really favorable results for a non-drug device, which is pretty exciting. But it's interesting. If you look in Europe, when this device was combined with some of the medicated balloons, the results were even more impressive. So, we're talking incredible patency rates in terms of the vessel stayed open for long term. And that's what really kind of pushed us to create the drug version, which will be forthcoming. Hopefully later this year, we're going to be starting that trial. And I'm the global PI along with Dr. Mahmoud Razavi for that study. And I think we're really excited because that's going to be, the next generation of this technology, the natural iteration.
And the theory behind that is, you're kind of poking holes in the skin, so to speak, much like you would do for a fruit of some sort to elucidate the juices. So you've got the holes, so now you can get the drug that kind of works its way in. So that's pretty exciting. I think that'll be we're looking forward to helping out on that as well. But Jay, the 6-month mark, because people will ask, the doctors and physicians that are listening in, do you think we need longer term data, or is it just, hey, the wound healed, we're good to go? We talk about durability. Does it matter if the vessel's open in anything, whether it's a stent or this or something? Does it matter if the vessel's open at a year mark?
So it's a controversial thing, right? So it depends on who you talk to, right? So what's the primary goal of these types of interventions? Is it to maintain patency, which is a nice thing, or is it to try to heal wounds? And the reason why we have this mindset that we want to just heal wounds is because we've never had anything that's given us really long-term data until relatively recently, where, I think Esprit, had some pretty nice year-long results in comparison to some of the other things that we've done before too with ballooning. So I think the 1 year mark is going to become in the future kind of the standard for at least when it comes to patency, but it may not really matter when it comes to trying to heal wounds. We want to get enough blood flow so that the wounds heal, the patient still can be saved from amputation. If you have patency, it certainly is a nice number to look at and to talk about. But if you have a patent vessel but an amputated, a partial amputation, well, then were we that successful? I mean, perhaps, but ultimately the goal is to try to save as much a limb as possible.
And that speaks to the fact that it takes a village to take care of these folks. I mean, you and I are plumbers to some degree. I don't do wound care. I don't think you do either. But I mean, like, we work closely with wound care folks, and so it's just a collaborative effort to, at the end of the day, you got to take care of the patients, and like we said earlier, it's patients over product.
And what we at the Global PAD Association always say, that these procedures are basically used to heal a wound and to give you enough pain relief so that you can get out and walk to grow those collateral vessels so that you may never need another procedure again. Get those collateral vessels rocking. Well, coming up on the Heart of Innovation, we'll have more with Dr. Matthews and Dr. Phillips talking about the spur technology. And guess what? Next step, could it be the heart? Stay with us to find out. Don't go away.
I say to the patient, there is data out there that shows that in a patient who is a claudicant, which is just a fancy Latin way of saying it hurts when I walk, if we go in there and we intervene on you, you fall into a different bucket. And we know from a lot of data that patients who get unnecessary interventions for something that they could have dealt with by just walking have a higher rate of bad outcomes, including amputation. So what's our job here? We want to keep your legs virgin territory. We do not want to get in there and start rotoring and sticking stents in there and balloons in there if we don't have to. That would be crazy. It's like taking a person who's perfectly well shaped and doing liposuction on them unnecessarily. Someday when they may actually want it or need it, you've now created all this scar and caused all this trouble that procedure may not go as well as you want it to. It's a silly example, but that's the way I say it to people. People get it. Yeah, okay, I get it. It's an unnecessary procedure at this point. Then I tell them, you can take care of this problem by yourself. And not only that, if you take care of this problem, you do the walking program and you create those collaterals, guess what? Those guys are with you for life. If I go in there and I rotor through something and I balloon it open, you're going to get maybe a year, maybe 2 years out of it. And then I'm going to have to come back and then come back again for another touch-up and another touch-up. But if you build those collaterals, you've now built things that are going to allow you to get that blood flow forever. And the vascular system is all connected. So you're also going to be benefiting your heart and your carotid arteries that deal with the stroke risk side of things. So overall, your chance of death from heart attack, from stroke, and the pain in your legs, we can make vanish by you doing this walking program. So now they're interested. Now I got them on the line. Then I say, it's easy. This is what you need to do for me. I need you to go home, and for the next 5 days, every day, I want 30 minutes of walking. And they say, what, 30 minutes? I can't even do 2 minutes without the pain. I say, I know. I'm not telling you to do 2 minutes. What I'm telling you to do is, over the course of 30 minutes, I want you to start walking. When you feel the pain, I want you to keep walking. And then I only want you to stop when you have tears in your eyes from the pain. And they laugh. And I say, but you get what I mean, right? And they get it. And then I say, then I want you to only rest for as long as you need to start up again. So I don't care in 30 minutes if you start and stop 500 times or if you walk a full 30 minutes. I just want you to do 30 minutes where you've really pushed yourself. And I want you to document, this is the key, how long you walk before the pain starts, how far you can walk once you have the pain, and then how long you need to rest before you get up and walk again. And if you document this, what you will find is patients will get really excited because within the first week, they'll already start to see their times increase. Oh, it's taking longer for the pain to set in. Oh, that means it's working. And then they get motivated. The same way you'd step on a scale if you were trying to lose weight and you saw you lost 5 pounds from eating salads. Wow, you're going to do another week of it. And that's what I tell my patients. And then I tell them, Very rarely in medicine, very rarely, can I give you a guarantee on anything. But on this thing, I can guarantee you, if you don't smoke, okay, if you take your aspirin and your statin, and if you do this walking program the way I just described it to you, I guarantee you results. Why? Because multiple randomized controlled trials, which are the most powerful data trials that you can do, have come out that have clearly showed that for intermittent claudicants, again, which is people who have pain when they walk, if they do a supervised exercise therapy program, which is what this is called, a SET program, they do get a longer period of time where they walk before the pain sets in. Are you going to run the Olympics? Probably not, but you don't need to. What I try to tell them is, what I'm trying to do for you is I want to get to the point in your life when you get to go outside to the movies with your grandkids, whatever you want to do, and your legs are not on your mind. If that's the case, we've won. And that's what I'm trying to do. And they love it, and they go for it.
For those of you who like baseball, we are rounding third on the show, and hopefully we'll slide into home and win the game. And I think we won the game today. At least I feel like I did with the procedure today using the spur technology. But Jay, so it sounds like may not just be limited to the smaller vessels below the knee. Looks like there's an application potentially within the heart as well, right?
Absolutely, yeah. So it's, as we were developing this product for below the knee, made sense. This is a small device. Can we shrink it down even further and potentially put it in coronary arteries? And the idea here is that we were talking about stents earlier, and stents seem to do a good job to keep blood vessels open in the heart, but they're great until they're not. In which case, sometimes you have layers of metal in the heart, and you have a patient that develops another blockage. Well, what do you do? And we've been limited until very recently with some drug-coated balloon technology. The problem is getting that drug where it needs to go. And as we were talking earlier, maybe these spikes can penetrate into the wall, allow drug to actually get to where it needs to be, and can that potentially improve outcomes? So this same spur device has been developed for use inside stents, inside of the coronary arteries. And so that presents an exciting iteration of this technology.
That is exciting. And in the last few moments here, I just wanted to get both your feedback, tell people, like, what is it actually like to use this device that is so different for you than anything else out there that you're most excited about?
I mean, just for me, it's just exciting to be involved with something new and something different because, like I said, what we've had before has been the same technology that's been available since the 1990s. So the fact is that we got something that's completely different and new, paradigm shifting, is really exciting. So to me, I'm just super stoked to be there and be involved with this.
I think it's fantastic to have something new. I was really excited after this case because it's not often where there's a completely, as Jay said, a de novo device that I think we were the 7th in the country to use it in the FDA approval, post FDA approval. So I think again, an added tool to the toolbox, much needed. Looking forward to what it can do in the future, and then particularly in the coronaries as well.
If you both could wave your wands to do anything different in it based on your experiences, what would it be?
Me personally, these are long lesions, and it's actually kind of neat too because now you're getting a little bit into the nitty gritty of it. But so the spikes in the stent itself are what we call sheaths. So there's a covering on it, and so you have to pull that covering off. And typically, you have to take the entire covering off and expose the whole portion of the length of the stent. And actually, the way they designed it, you can unsheath portions of it. And I think one of our friends at Reflow, dial a length, DAL. That's the kind of the term he coined. So you can unsheath part of it and deploy it, and it works. So in a section, it doesn't damage the covering. So that's kind of cool too. So I think the longer lengths and that technology is fantastic.
And Dr. Matthews, 10 seconds. What do you think? Looking forward to the drug-coated.
Yeah, drug-coated. But then not just that though. There's sky's the limit. Bigger vessels, veins, dialysis patients. There's so many different applications. So super excited as to see what we can do. This is just the beginning.
And on that note, thanks everyone for joining us. We really appreciate you.
When your sugar runs high, it's more than a sign. Diabetes creeping in, it's a dangerous line. Pre-diabetes too, don't think it's too light. It can lead to PAT, so start the fight. Sugar's sweet, but the cost is real. High blood sugar makes your arteries feel clogged. Slow flow, it's a ticking time bomb. Catch it early, stay strong, and keep your legs on. Sugar's not so sweet when your leg is in pain. Not controlling sugar is where peripheral artery disease sets in. Got sugar? Get checked. Don't wait too late. Save your legs, save your life. Take control of your fate. Leg pain, cold feet, neuropathy too. These are signs diabetes caught you. High sugar's the link where circulation and pain left untreated. Your leg might end